1 to PerfectServe's Thought Leadership webinar series. As Ray said, I'm Wendy Barnum, and I will serve as your moderator today. We are pleased to sponsor today's webinar on interdisciplinary collaboration. Research has shown that communication breakdown is the primary contributor to delays in treatment. This is because the complexity is inherent in today's clinical communication processes. And this is why we are so excited to bring today's webinar to you. And before we turn things over to our guest expert, I do want to take just a minute and introduce you to PerfectServe. PerfectServe Synchrony enables healthcare organizations to effectively address the widest variety of communication-driven workflow challenges across all stakeholders. This communication and collaboration platform unites physicians, nurses, and other care team members across the continuum and facilitates timely interaction. Now communication can be streamlined, reliable, and efficient. We invite you to learn a bit more about PerfectServe Symphony on PerfectServe.com. And you can learn more about how to address the challenges associated with medical communications head-on. And at this time, I'm pleased to introduce today's guest expert, who's going to share best practices and proven strategies for improved collaboration within your own care teams. Catherine Verkstis is a practice manager for the Nursing Executive Center at the Advisory Board Company. During her 10 years with the Advisory Board, Catherine has focused on uncovering best practices in nursing, with a spotlight on clinical quality, efficiency, readmissions reduction, nurse engagement, and strategic planning. Catherine is also a well-published author and also sits on the editorial board of the Journal for Nursing Administration. Previously, Catherine practiced family medicine in central Vermont. Thank you so much for joining us today, Catherine. I will turn things over to you.
Thank you, Wendy. And thanks to everyone for joining us today. As Wendy said, I'm Catherine Verkstis, and I oversee the Nursing Executive Center at the Advisory Board. And, I'm fortunate enough to spend my time thinking about and talking with executives across the country about care delivery, how we can improve care coordination, and really how we can take advantage of a market that now rewards value, not volume. So, I'm really excited to be here today to present this research with you. I'm going to jump right into kind of my roadmap and give you a sense for how I want to use our time today. I'm going to begin with why we now have a renewed focus on interdisciplinary collaboration and why working together as a unified team will be critical. I think it's always been important and critical, but why it's going to be more critical than ever in today's world. And then I'll spend the rest of our time, I guess the rest of our 55 or so or 50 or so minutes, sharing 10 best practices for enhancing partnership and communication across the entire care team. Our focus will be on collaboration within the inpatient setting, and this is an important distinction. This is really strictly due to our time constraints today. We only have an hour. In a perfect world, we'd have a whole day, and we would talk about interdisciplinary collaboration across the entire continuum. But since we have just an hour, I'd argue that the acute care setting really is the right place to start. In case you're interested, the Nursing Executive Center that did take on a major research initiative this year. It's called Achieving Care Continuity. It's not just about perfecting warm handoffs, but tackling all the root causes of why we still often provide care that's fragmented or episodic. As you can imagine, a big part of that solution is how we collaborate more effectively as caregivers, both within and across disciplines and within and across sites and settings of care. So I want you to know that's available. It's a major research initiative we took on this year. But for our purposes today, we're going to dive into inpatient interdisciplinary collaboration. And I want to start really by defining our terms up front today. So the words communication and collaboration, we find in the literature, are often used interchangeably. But at the Nursing Executive Center, we see them as having very distinct meanings. On the left, communication can be defined as the exchange of information or ideas. But on the right, I see true collaboration as much more than just communication. It's sharing responsibility. It is solving problems as a team. It's drawing from each other's expertise to make more informed decisions, and of course carrying out the plan of care in a cohesive way, both on our end and then also from the perspective of the patient. So really, here's the key point. While communication and collaboration are distinct, they're both critical here. They're both important, and one is actually a prerequisite to the other. So as I share this research with you today, you're going to hear me talk about both communication and collaboration because they're both necessary. But what I won't do is use them synonymously. Instead, I'll be essentially drawing from the definitions you see here. Now, I'm guessing that because you selected this topic and decided to join this session, you don't need convincing that strengthening interdisciplinary collaboration is important. But I think sometimes it's nice to see it quantified. So across the next few slides, I'm going to share some data and examples that do quantify what you probably already know intuitively, and that is that strengthening interdisciplinary collaboration can have a deep impact on a few things. And the first one is clinical quality. The second is patient experience, and the third that I'm going to quantify is costs. So let's go through each of those. I'm going to start with clinical quality. The bar graph that you see here, really confirming what you already know, that interdisciplinary collaboration is closely correlated with clinical outcomes. So as collaboration levels rise, the likelihood of negative outcomes fall. And as we increasingly shift into this, what we're calling a value-based market, one might argue that achieving better outcomes really has never been more important than it is now. But as I mentioned a moment ago, strong collaboration can have an impact on more than just quality. Let's take a look at the next example. So here's just one example of how communication failures can have a negative impact on the patient experience. These are common failures you're probably familiar with. So, for example, patients asked to repeat the same things multiple times. Maybe one caregiver can't explain why the plan of care changed or perhaps the day of discharge changed. Patients might receive conflicting information from multiple caregivers. So collectively, all of these failures, I think, run the risk of leaving the patient with the perception that his or her care was poorly coordinated and maybe even substandard. Now, these first two reasons I've just covered on these last two slides, so clinical quality and the patient experience by themselves, I think, are enough of a strong reason to focus on strengthening collaboration. But there's a third, and it's one that we literally can't afford to ignore, and it's right here on my next slide. So here you see the reported results of one study estimating the annual economic burden of communication inefficiencies. The pie here showing estimated cost of wasted physician and nurse time and the cost of increased length of stay for an average 500-bed hospital. I personally found these numbers to be staggering. So each of these values alone is powerful, but look to the bottom of the slide. When you sum them up, at least according to this one study, the average 500-bed hospital will spend more than $4 million annually on inefficient communication. I would say based on these numbers, I'd argue even if you're ahead of the curve, if your organization is performing above average on communication, there's likely still a significant opportunity and really a strong business case for investing in improving the communication and the collaboration between different members of the care team. And as we look to the future, we'll need that investment because unfortunately, collaboration isn't getting any easier. As you can see on the slide here, we have new challenges now, making interdisciplinary collaboration more complicated. So starting on the left here, care teams are now larger, right? They're more specialized. So we've got more cooks in the kitchen, if you will, and collaborating effectively, I think, just simply requires a greater effort. Moving right, patients are more complex. There's just more stuff to collaborate about. Patients have multiple comorbidities, lots of things going on. And then on the far right, proliferation of communication technology. It's really designed to help us communicate more efficiently, but it also means we're not always talking to each other in person. And the trade-off is we may be sacrificing the quality of those exchanges to some extent. So all of this leads me to this question, kind of what the heck do we do about it? How do we foster collaborative relationships across our care teams? Well, to do that effectively, our research team surfaced three important barriers that I think we'll have to overcome. The first is, let's be honest, face-to-face communication is often falling short. And if we can't fundamentally exchange ideas or concerns, we won't get very far with the goal of building a truly collaborative environment. Second, most of the time, we can't communicate face-to-face because we're simply not in the same place at the same time. So it's a real barrier. And then the third barrier is that different caregivers, especially across disciplines, may be focused on a completely different set of patient goals. And if we want to advocate for our patients with a unified voice, we're going to have to do better. So across my next few slides, I want to walk through each of these in turn. And I'm going to start with my first barrier here on the next slide. So what you see in front of you here on this slide, some interesting results from one study concluding that we're often failing to fully discuss concerns about the behavior of other colleagues. So on the left, a sizable percentage of nurses expressing concerns about clinician competence, poor teamwork, or disrespect. Yet on the right, a very small percentage reporting they confront colleagues about those behaviors. And unfortunately, when it comes to in-person communication, being willing to speak up is only half the battle. The other half of the battle is ensuring that when we do speak up, we're conveying that information fully and accurately. This is data from a study conducted on communication failures in the OR. The pie on the left indicating communication failing nearly a third of the time, and on the right, the root causes of those failures, with the majority resulting from poor timing, failing to communicate to the right people, and then failing to communicate information that's either complete or accurate. But the problem, of course, is that even if we perfect face-to-face communication, there's still that very real challenge that more often than not, we're rarely in the same place at the same time. This was that second barrier that I shared with you a moment ago. And just to kind of illustrate this for you, this is a representative daily schedule for hospitalists and RNs, which was shared with us by Northwestern Memorial Hospital. And when you scan this table, I think probably what jumps out at the page at you, at least what I noticed, is that while nurses and physicians may be caring for the same patients, they aren't often physically working side by side. I suspect this is true for many of you and for your own care teams. And so I think when you consider this reality, it's really no wonder we're struggling to collaborate across disciplines effectively. All right, so that was our second barrier. And of course, I've saved the biggest challenge for last. As I've shared the first few barriers, we're operating under the assumption that all care team members are working from the same playbook. But I think when we did this research, that was the big elephant in the room. It's that oftentimes we're not working from the same playbook. So data here showing that nurses and physicians are not in full agreement on patient priorities more than 85% of the time. So at a fundamental level, this is a real problem. And if we don't agree about what patient goals are most important, then we'll certainly have trouble coming together on how to resolve more complex challenges and make critical patient care decisions as a unified team. So just to recap here, I've just walked through three barriers to effective interdisciplinary collaboration. The first was face-to-face communication falling short. The second was care team members are often separated by space and time. And the third was that care team members focus on different patient goals. So that brings me kind of to our framework for today. This is the Nursing Executive Center's framework for cultivating partnership and communication across disciplines. And then, of course, the associated best practices for addressing these barriers head on. Just to run you quickly through this, so we're going to start with tactics for strengthening in-person interdisciplinary communication, which again, I think is the foundation for all of this. We'll then look at ways we can bridge the barriers created by the reality of today of being separated by space and time. And then I'm going to finish today with, I think, what I would consider the toughest barrier to overcome, since it's going to require some cultural shift to some extent, and that's ensuring the entire care team shares the same patient goals. I know that you've all been briefed on asking questions. I'm going to kind of run through all my remarks today, and then we're going to have a few minutes at the end to answer those questions. But feel free as we go, if you've got questions, just go ahead and type them into your question bar. Now, before I jump in, I'm going to just the brief caveat that I touched on a little bit earlier, and that is just recognizing as we move into a more value-based world, it's going to be absolutely critical to strengthen collaboration, not only across disciplines within the acute care setting, but also across the continuum. So just a reminder, I really am just focusing on the inpatient setting today, and it's just because of our time constraints. All right, so without further delay, let's just jump right in to our first column here. In our research, we surfaced 3 common failures of face-to-face communication. Starting on the left here, it's a reminder of data that I shared earlier. Confronting a colleague when you have concerns about his or her behavior, it really isn't easy, right? Especially if that person is in a position of authority, if you don't know him or her well, or if that person is more tenured than you are. So it's a real challenge. Moving right, team members communicate either too little or too much detail and fail to pinpoint the most relevant information. And then finally on the right, we're human, and we just don't always hear each other accurately. Now, what's important here is that any one of these failures can put our patients at risk. So we can't just pick one hurdle to overcome and do that really well. We actually have to be certain we're addressing all 3 of these failures or challenges. So in this column, I'm going to share some pretty simple and straightforward ideas for how to prevent these failures. Some of these are going to be tools you're already familiar with, and I've included them not because they're new ideas, but I think because they're important. And I want to make sure you've got kind of a checklist, if you will, of things to think about as you go through this. So with that backdrop, I'm actually going to move through this column very quickly. And I want to start with the first failure. This is practice number 1, and we call it in-the-moment safety scripting. I'll start by sharing the story of Air Florida Flight 90, which many of you remember crashed into the 14th Street Bridge in Washington, D.C., only about 30 seconds after takeoff. Now, this happened about 30 years ago, but I'm going to share it because the lessons are still very relevant today. And if you review the transcript, you notice some interesting parallels. In fact, I bet nearly everyone on the line today has personally felt hesitant to speak up at one time or another. If you, as a nurse leader, has felt this way, think about how often this can be an issue for frontline staff, especially for new graduate nurses. So one way to address this very real concern is to provide a tool that empowers frontline staff to speak up and to create kind of a safe space for them to voice safety concerns when it matters, and that's in the moment. So that's exactly what Vidant Medical Center in Greenville, North Carolina did through a scripting tool. I'll acknowledge many of you have done work in this area, and I share this as kind of one great example. The tool on the slide here is known at Vidant as the AAA framework. It stands for Ask, Advocate, and Assert. The goal is really to enable bedside caregivers to speak up when they notice any potential safety issues. And so staff use the 3 keywords that you see in the second column to signal their perceived level of urgency to other providers. I'm confused, I'm uncomfortable, or I'm scared. And by literally giving them those words, we're empowering them to use them and to speak up. You can see the sample scripting here on the right and the associated action triggered by each of these keywords. And I would also say, the magic here isn't so much in the words they use, it's that they have a clearly defined link between the words and the appropriate actions. I think it can seem like a simple idea, but in the context of acute care, a tool like this can potentially mean the difference between life and death. Okay, so this first practice addresses the issue of ensuring caregivers speak up in the first place. My second practice ensures that when care team members do speak up, they're sharing the right level of detail. So you're all, no doubt, familiar with and probably using a very widespread tool used to address this issue. It's SBAR. But, one of the biggest challenges I hear about SBAR is how do you get people to use it, and how do you get people to use it effectively? When the SBAR format is not followed, the information shared often falls into one of two pitfalls. First, skipping over critical details or being unprepared to answer questions when asked. And second, and I think this is the more common one, providing too much information so that critical details get lost or buried. So what we have here is the SBAR Pocket Guide, and it's designed to help caregivers use SBAR more effectively by clarifying what information to have on hand. And I'd argue if SBAR is used more effectively, it's also likely to be used more often. Now, to truly get the most out of the SBAR Pocket Guide, we'd recommend training nurses to use it through role play exercises. And here you can see a brief overview of steps for this exercise and a short list of questions to guide discussion following the role play. I'm going to leave these details for your later review, but I do want to point out the box at the bottom of the slide. Both the SBAR communication support tools as well as the previous practice in the moment safety scripting are both shared in greater detail in one of our resources called the Critical Thinking Toolkit. If you've got questions about this or want to learn more about it, just let us know. The other note I'll make here is, role play can be very powerful. I think in healthcare, we don't do role play enough. So it's just something to note, even when you've got a tool like this in place, the difference between doing it and just doing it and doing it really well can be having a few role play sessions together with the caregivers who will be working together on a day-to-day basis. Okay, so I now want to address the third communication failure, and that was when communication is not heard accurately. And this is practice number 3, closed-loop communication. It's an example of another just extremely simple and straightforward process that can have an outsized impact on patient safety. The concept here is not rocket science, and again, many of you may have heard of this. When one caregiver provides verbal instructions, the receiver of those instructions repeats them back to ensure they were understood correctly. This is actually one of many safeguards that were developed by Team Steps, and many of you may also be familiar with Team Steps. It's something that a resource we think is really valuable and a strong organization to tap into for some of these types of resources. We also have within the advisory board a talent development division that provides team training tools in the form of in-depth, interactive, and facilitated training modules. So another resource there, if there's something you're interested in, just let us know. Now, I'm not going to get into any specifics of the talent development module, but I just wanted to share this. We've got it in your handout for you. Okay, so this brings me to the end of my first column on improving face-to-face communication. But of course, that's only part of the solution, especially when you consider that so often we're not actually in the same place at the same time. So I want to jump in now to my second column, and I want to share a few thoughts on how we can bridge those barriers created by space and time. You can see there are 3 practices listed here, ranging from an exceedingly simple idea that anyone can implement to 2 processes requiring a bit more planning and reorganizing. So let's just begin with the easy one. This is practice number 4, nurse-physician communication sheet, and it was developed by leaders at Central Baptist Hospital in Lexington, Kentucky. These leaders realized that communication between nurses and physicians was often getting lost in the shuffle. So when patients, family members, or care team members had questions or comments for a patient's physician, the nurse would often leave a Post-it note or even write a note right in the patient's chart. But as you can imagine, this haphazard system was full of cracks. The Post-it note falls off the chart. The physician doesn't turn to the page, the chart where a note was left, and even when the doctor does find the note, it's impossible for the nurse to know whether the message was received or if the concern was addressed. This could even be true in an electronic medical record. Their solution is what you see represented here. It was a bright orange sheet attached to the front of the chart used explicitly for communication between nurses and physicians. You can see that the simplicity was truly the key to the success here. And the 3 reasons right in front of you. So first, the tool formalizes a clear channel for non-urgent communication between nurses and physicians. Second, once the physician reads the nurse's comment, he or she then checks a box to acknowledge the issues being addressed. And then third, it doesn't become part of the patient record. The sheet is shredded after questions or comments have been acknowledged by the physician. Now, of course, there will always be times when a nurse has something urgent that needs to be communicated to a physician right away. So here, I've shared some quick guidelines for using the shared sheet. As you can see here, nurses will, of course, call or page the appropriate physician right away for anything requiring immediate attention. So, for example, a deteriorating patient condition or a reaction that could be life-threatening. But in the bottom row, some examples of non-urgent needs and when it may be more appropriate to use the shared sheet. So, for example, if a patient or family member has questions about a lab test that was already performed or a procedure that's scheduled 2 days from now. And I will note, again, this was originally designed when this organization was in a hybrid world. This is certainly something you could build into your EMR, a specific place where you have communication between care teams. Now, I began our discussion today by making the distinction between communication and collaboration. So far, we've largely been exploring ideas for how to communicate better. But of course, to provide the best possible care for our patients, we're going to need to do more than just communicate. So my next 2 practices, and for the most part, the remaining practices I'm going to share today, we're going to move beyond the challenge of communication to truly strengthening interdisciplinary collaboration. Now, I'd say the number one strategy I hear about for ensuring care team members collaborate across disciplines is interdisciplinary rounding. In fact, data from the advisory board survey tells us that roughly 95% of member organizations have already implemented interdisciplinary care teams. But when we really got behind this data, we realized there's often a pretty large gap between just doing this and doing it well. You can see to the right a listing of the pitfalls that we repeatedly found, and they range from inadequate attendance to inefficiency. And I suspect that many of you, if you've had experience with interdisciplinary rounding, you may have run into 1 or 2 of these pitfalls in your own experience. The good news is we also found a number of organizations that really have reinvigorated interdisciplinary care conferences and have done so with great success. And the secret are the 4 elements that you see here. So first, when we looked at across all of the organizations who are doing effective care conferences well, every one of them were doing these 4 things. The first one was to create unit-based ownership. So the structure that works for one unit may not necessarily work for another. Second was to organize patients around providers. Unless physicians have patients that are cohorted on the same units, they won't physically be able to get there on a consistent basis. The third was to keep conferences focused with a clear agenda to ensure they're succinct and efficient. And then finally, everyone who was doing this well told us you've got to establish clear roles for key members of the care team who are attending the conferences. So our question was, well, how do you do these 4 things well? And I actually want to run through each of these one at a time. And I'm going to begin with the first element and the practice now in place at Northwestern Memorial Hospital in Chicago. So to create unit-based ownership, Northwestern recommends every unit implementing interdisciplinary care conferences hold a few planning sessions, starting several weeks in advance of a process rollout. There should be 2 principal aims of these collaborative sessions. You obviously want to ensure the plan structure takes into account the unique needs of the unit and works for the team, but also build a sense of shared ownership and a sense of commitment, a personal investment in making the structure work. Now, unfortunately, what we've got to do excel on the second element is a bit more complex. Literally, every organization we spoke with that had effective interdisciplinary care conferences in place told us You've got to create a structure that allows physicians to physically get to the conferences. You simply won't be able to rely on the promise of a consistent participation to overcome those physical realities. And really, without physicians, the whole thing falls apart. Maybe not immediately, but eventually. Furthermore, a number of these case study institutions emphasized that matching staff to physicians is not a second-best alternative, because then both physicians and nurses wind up running all over the hospital and still struggle to attend the conferences. So the critical point here is you've got to cohort the patients around their providers. Now, even when you have the right people in the right place at the same time, you can still run into problems if you allow the conferences to be free-form discussions. And that brings me to my third element of successful interdisciplinary care conferences. That is, keep them focused. And fortunately, I think achieving this one can be relatively straightforward. Northwestern went to a long-standing solution. They use a simple communication tool with a standing agenda to focus their conversation on most critical information. Moreover, the teams at Northwestern stratify the time they spend on each patient. So the communication tool on this slide is used only for patients who are new to the unit. For all other patients, the physician provides a quick 2 to 3 sentence update and then invites input from the rest of the team. Another organization who does this well is Johns Hopkins. They have not only clarified what should be discussed during the conferences, but also each person's role. Remember, this was our fourth element. I'm going to leave the details for your later review, but one especially important role is the facilitator. So this is often the unit's charge nurse, but again, that's not a hard and fast rule. That's going to end up being a unit-by-unit decision. This is someone who holds everyone accountable for attending, keeps the conferences moving, and then also ensures any follow-up is owned by the appropriate caregivers. On my next slide, you can see evidence of the return on all this effort and why we often think of interdisciplinary collaboration as kind of the special sauce. Greater agreement between care team members, meaningful reductions in adverse events, and unexpected efficiencies as well. Post-implementation of interdisciplinary care conferences at Johns Hopkins, pharmacists were able to free up 3 hours per day, time they had needed to round on patients individually, that they then redirected to the new patient care responsibilities that you see on the right-hand side of the slide. And when you look at those new responsibilities taken on by pharmacists, you may notice something. They're all patient care responsibilities. So increasingly, we're seeing more organizations use pharmacists as more active members of the care team, physically working side by side with nurses and physicians and providing more direct patient care. In fact, one of the strategies for bridging the barriers created by space and time is to just remove it. And that's exactly what Southeastern Regional Medical Center and also the Hospital University of Pennsylvania did. Let me show you what I mean. So leaders at Southeastern Regional literally pulled pharmacists out of the basement and gave them a home base right on patient care floors. You can see the details of this reorganization on the slide in front of you. And I want to be clear here. They didn't need to build anything new to accomplish this. So each floor-based pharmacist now has a small desk and a computer at the nurse's station and is more available to collaborate in person with physicians on medications, dosages, potential side effects, and with nurses on medication administration and potential reactions to watch for. Anecdotally, nurse leaders at Southeastern told us that because the pharmacist is right there, both nurses and physicians found they asked more questions and really just collaborated more often on both medication and pain management. Another example was Hospital University of Pennsylvania, or HUP. They have not only shifted the location of pharmacists, but also their role. So at HUP, pharmacists have been based on patient floors for about 10 years, but more recently, the floor-based pharmacist roles were expanded to include more direct patient care, including things like patient education, input on medication management, discharge planning, etc. And as you might suspect, Involving pharmacists more directly in patient care not only strengthened care team collaboration, but it also played a role in improving quality on the pilot unit. Okay, so that brings me kind of to the end of my second column. To be clear here, the three tactics we just discussed aren't the only ways to bridge barriers created by space and time, but hopefully it gives you three very different options to start with, depending on where your organization's greatest needs are. And if your first step is to tackle nurse-physician communication, you might start with the shared sheet. If you're more ready to address collaboration barriers, you'll want to focus on one of the other two practices I just shared. Okay, so that brings us to our third column. And again, as I mentioned before, I think this is the most difficult one to overcome, and this is ensuring the entire care team shares the same patient goals. And if we don't fundamentally begin with the same ends in mind, we're really never going to be able to function as a cohesive team. So we believe this will be the most important challenge to overcome. So I've dedicated a little bit more time here. This is practice number 7. I'm going to jump right in, and it's called goal-driven protocols. We addressed this a couple of years ago in our work on elevating frontline critical thinking as a strategy to help nurses avoid the pitfall of what we call task-focused tunnel vision. And I share it here because I think it's very appropriate for our conversation. So to address this challenge of task-focused tunnel vision, Columbus Regional redesigned select protocols to shift caregiver focus from completing tasks to achieving patient goals. So rather than being a checklist, the redesigned protocol is focused on explicitly stated patient goals. In addition to shifting the nurse's focus from tasks to patient goals, the redesigned protocol also enhances multidisciplinary collaboration. So in the redesigned protocol, before moving to the next step of interventions, both the nurse and respiratory therapist must sign off as each interim patient goal is achieved. And this ensures really that the patient is ready for the next step. It also improves the care team communication and coordination. I only had room to show an excerpt of the protocol here. Note that all of the things here that you see in my slides that are excerpts, for almost all of them, we've got the full tool available. And there's an appendix that we can share if that's something that you'd like to see. Now, it's important to note that really not all protocols are right for redesign. So based on Columbus's work, I want to share just a few considerations for determining which protocols you may want to consider redesigning into goal-driven protocols. So first, goal-driven protocols should be condition-specific and not preventive, so there are clear patient goals to work toward. The second one is you may want to prioritize protocols that are used by a multidisciplinary team. So this enables different members of the care team to all work toward the same patient goals. And then third, you'll want to choose protocols that are frequently used to ensure that care team members can use them effectively. It's just not worth it if it's something that you only pull out, once or twice a year. And then take a look at the results. Leaders at Columbus told us that for years they've been trying to reduce vent time to less than 6 hours following heart surgery, but it wasn't until the implementation of the goal-driven protocol that they were successful. And in addition, they tell us they have virtually eliminated the need to reintubate patients after weaning from the ventilator. But I'd argue if we want to ensure the care team is working toward the same set of goals, we also have to include patients and their families. And that brings me to my next practice. This is practice number 8, and it's called the Daily Patient Roadmap. Leaders at Abington Memorial Hospital in Pennsylvania recognized they could improve patient education by sharing their care plans directly with patients. So they created an automatically generated report that outlines a patient's plan of care. It's kind of a snapshot of care for the day. The magic in this document is that any potential confusing medical or nursing terms have been converted by the EMR into plain English that patients can understand. Let me show you what I mean. So what you see here are sample clinical terms on the left that might be part of a patient's care plan. And then to the right, the patient-friendly translation. So for example, oximetry routine translates into plain English as a test to check the percentage of oxygen in your blood. And then take a look at the results. Since its introduction in 2009, the daily care plan has identified a number of near misses, nearly all of them identified by patients. The process of reviewing the daily care plan with patients provides them this opportunity to say, hey, the medication I'm allergic to isn't noted here, or that's not the dosage of medication that I take at home. And on the right, strong increases in the number of patients who reviewed their daily care plan through a structured conversation with their nurse. I really love what Abington has done here, but before I kind of move on from this practice, I actually want to share another organization that took this concept a little bit further, and that's Lehigh Valley Health Network. Leaders at Lehigh wanted to be sure patients not only understood their goals, but also their role in achieving them. For example, you can see here how a similar tool clarifies what patients are allowed to do and what they need to learn about on a given day. This is an excerpt of what Lehigh Valley calls their roadmap, which is an acronym that stands for Review of All My Daily Medical Actions and Plans. So the roadmap prompts patients to ask questions about tests, about procedures that they may not fully understand, and it provides an open field for patients to jot down notes about any other questions or concerns they might have. Usually patients are hesitant. They don't want to bother nurses or physicians. They feel that they're busy. By giving them this kind of a form to fill out, we're actually giving them permission to ask. I do want to share how nurses at Lehigh build the roadmap into workflow. You can see that on my next slide. So just like Abington Memorial's daily care plan, the report here is largely auto-populated by EMR inputs. I want to acknowledge there are a few brief fields that nurses at Lehigh must complete manually, including procedures scheduled for that day and what patients need to learn about. On admission, the nurse reviews the roadmap together with the patient and orients him or her to the process. And then on subsequent days, the roadmap is literally handed to the patient during a daily bedside report. And the roadmap is then left at the patient's bedside in a folder with a pen attached, and that's important because they told us at first they didn't use a pen, and patients don't tend to carry pens with them, so the patients can review and make notes as needed throughout the day. And then finally, the patient's nurse checks back in during rounds later in the day to ask if the patient has had any questions or concerns that he or she would like to discuss. You can see how the roadmap is impacting patient satisfaction scores, and based on the positive feedback from patients and care team members, the organization then rolled the initiative out to the entire system. Okay, so we've just talked about a few tactics for ensuring caregivers and patients are both working from the same playbook. But what if care team members across disciplines had a role in actually writing the playbook together? Not only would everyone be bought into the same plan, but we'd also ensure each professional's expertise was incorporated. Well, there are a couple of ways to accomplish the aim of having caregivers work together across disciplines to write the playbook. The first is through one-off clinical initiatives, and the other is to build interdisciplinary collaboration right into the unit or hospital infrastructure. And I'm going to talk about both, starting with an example of a one-off clinical initiative. This is practice number 9, collaborative quality improvement, which comes to us from the Methodist Hospital in Houston, Texas. After identifying the need for more effective pain management, a nursing director and clinical pharmacist partnered to structure a multidisciplinary pain management program. You can see the key elements of the initiative on the slide. Targeted pain management education for all care team members, interdisciplinary daily pain management rounds, and unit-specific pain management tools created together by pharmacists and physicians. I'm really just top-lining these components because the point I want to make is it's not how they tackled the challenge of pain management. It's that they developed and implemented the plan together. It was a truly collaborative effort between pharmacists, nurses, and physicians. We saw pretty impressive results. In just 1 year following the implementation, average patient satisfaction with pain management jumped from 72% to 97%. Now, I suspect many of you have identified one-off opportunities like this one to have care team members across disciplines work together to overcome challenges and improve care quality for their patients. It can be a powerful way to improve care quality while also improving interdisciplinary collaboration. But the other strategy I just mentioned for having caregivers kind of write the playbook, if you will, is to create an ongoing infrastructure. What's different there is that rather than relying on one-off opportunities, you're literally baking interdisciplinary collaboration into every single unit level decision. In our research, we found one organization that was doing this particularly well, and that was the University of Pennsylvania Health System. This is our final practice, and it's called unit-based clinical leaders. What UPenn has done is to establish this unit-based interdisciplinary partnership. And as you can see here, each unit-based clinical leadership team, or UBCL as they call it, is comprised of a physician leader, the unit's nurse manager, and a quality leader. And you can see each member's individual role here. So the triad works as a team, meeting together weekly to review data and develop action plans for the unit. Importantly, the UBCL team doesn't just select their own goals randomly. An important role for the team is to ensure their unit-based initiatives are aligned with the larger health system's goals. So here's how it works. The UBCL begins by reviewing UPenn's blueprint for clinical quality and safety. It's a document essentially that outlines the health system's most critical strategic priorities. Next, the team analyzes unit-specific data to identify the unit's greatest opportunities for improvement. And then moving right, the team selects unit-based initiatives that advance both system goals and the unit needs. And then finally, the UBCL triad works directly with the unit staff to design and implement the initiatives. And while most of the team's work is focused on the unit, the UBCL also collaborates with key individuals beyond the unit. So each UBCL team meets monthly with the system-level CNO, CMO, and a head of quality to ensure their unit-based initiatives are closely aligned with the larger health system strategy, and then also to discuss any challenges or needs that they might need help with. And then on the right, all the UBCL triads from across the system come together once per quarter to share best practices and lessons learned with each other. It's this opportunity for them to really share what are the challenges we encounter and how do we overcome them with other UBCL teams. Now, one of the things I was wondering, and you may be wondering, is, how does UPenn select their unit-based clinical leaders? So across the next couple of slides, I want to share some of those details. On each unit, the nurse manager automatically serves as the unit-based nurse leader. Moving right on my slide here, quality leaders are either existing quality managers or new hires with experience working in direct patient care. And then finally, the physician leaders are handpicked based on leadership potential and their interest level. They're expected to dedicate about 20 hours per month to the role. One side note here, leaders at Penn noted that for a handful of complex units, such as surgical units, there may not be any single physician who's able to dedicate 20 hours per month. So to overcome this challenge, UPenn selects 2 physicians to serve as co-leads for those particular units, and then they split their time dedicated to the role, about 10 hours per month each. Perhaps more importantly, the way they generate physician interest in this role is to position it as a highly regarded opportunity. And what I've shared here is an excerpt of UPenn's physician appointment letter. Really, the point here is there are 2 levers to pull to get physicians involved. The first is an appointment directly from the CMO, and the second is providing a stipend to cover the roughly 20 hours per month of the physician's time away from patient care. And you can see on my next slide that UPenn's efforts really have been paying off. So since the program has been in place, units with UBCLs have seen fewer pressure ulcers and 33% fewer central line infections. And you can see at the bottom of the slide the cost savings. So this was their estimate of cost savings from preventing central line infections alone. This doesn't account for the other cost savings that you would expect to see from the efficiencies in terms of improving collaboration. And on the left here, just a sample of a long list of positive feedback shared by nurses, physicians, other members of the care team working on units that have UPCL. So overwhelmingly, the staff reporting they now communicate more effectively and better understand each other's roles. And on the right, a more quantifiable way of looking at how caregiver actions are more closely aligned with system-level goals. So since implementation of the UBCL program, the organization has seen a big jump in adherence to certain policies, such as the 24-hour med reconciliation policy that you can see. Certainly compelling results. And while there is a substantial reorganization involved, if our end goals are to improve clinical quality and reduce costs, I think a structure like this may be worth consideration. So I know we have just a few minutes left. This takes me to this was our final practice of the day, and it concludes my formal remarks. I now want to hand it back over to Wendy, and we're going to use our last few minutes together for some Q&A.
Thanks, Catherine. That was really great. A lot of great quantitative data there to support a lot of these practices. So that's really great to see. Thanks for everyone for submitting your questions. We do have a number of them that were submitted. Thank you. And we'll do our best to get through as many as we can in our remaining time. So I'm going to start with one. It came in a bit earlier in the presentation. I think this question is referencing Central Baptist Hospital's use of the nurse-physician communication sheet. The question is specifically, how was it implemented into the EMR? Can you provide a little more detail around that?
Yeah, when Baptist Health first created this, they were in a hybrid world, and they found that what they had happening in the moment was sticky notes. People were actually using sticky notes to send notes to one another. The sticky notes were getting lost in the shuffle, and so what they found was they needed to formalize that process with the shared sheet or with a standardized form. That to them made a difference in the moment. I think with respect to documentation, everyone is in a different place. Most organizations are still in a hybrid world. Most organizations also now have some level of electronic documentation. So I think this is something you have to work with your IT department to create or to develop and build into your EMR. I think certainly having this be electronic is ideal. But the point here was they created a special place where they could have this communication with each other that either can become part of the record or can be separate from the electronic record.
Great. Thank you for that.
Mm-hmm.
There was also a question, and I apologize for not remembering what slide it was on, but I think you must have had included a statistic about the cost of wasted time due to poor communication. Can you provide a little background on how that was determined?
Yeah, the source of that particular study is included in the slide, and I always encourage people to go back and look at the original source material. And if it would be helpful, we can send you kind of a citation or, a link to where you can pull that exact data. But as you can imagine, when you have poor communication and collaboration, it means things have to be repeated. It means often the wrong person is being reached, or it takes time. Sometimes poor communication and collaboration means that there's a poor response time. So there can be many reasons why you can have inefficiencies. But I would always recommend you kind of go back and look at the original source. And we'll always include those in our materials.
Great, thanks for that. And I do have a couple questions in here about folks wanting to get their hands on slides. I will be sending an email post-event that will include the slides, and we'll make a point to include that source information, Catherine, that you're referencing. I think these folks would enjoy receiving that, so thank you.
Mm-hmm.
Next question. When Lehigh Valley introduced their patient roadmap, did they encounter resistance from staff, feeling it might be another to-do?
Oh, yeah, that's a great question. I spoke with Lehigh, the leaders at Lehigh Valley directly, including the CNO and the entire team that rolled it out. And what they told me was, gosh, they were anxious about whether or not they would receive resistance. But what they told me is they involved not only frontline nursing staff all along the way, as and interestingly, they actually took Abington's form when they created their own roadmap. So they built on Abington. And they included frontline staff in the vetting process of creating their own roadmap. They also included physicians. So they found that when they were ready to roll this out, they actually didn't receive any resistance at all. People were excited about it, and they felt personally invested because they hadn't been involved in the development. The other thing they found is that it decreased their number of call-outs. And so by showing the staff that data, I think they immediately were on board and excited about the roadmap, and it just became something that was easy to roll out to the entire institution. Great question.
A great example of collaboration on that.
Mm-hmm.
That's great. I'm going to try to hit two more questions here. The CARE conferences, does an individual lead those or run those? One particular designated person? Have you seen that happen?
Yeah. So this was, I think it was either the third or fourth element on that slide when I talked about how you've got to make sure you have a set of clear roles for everybody involved, and probably the most important role you have is the facilitator. We've heard often that the person who serves as a facilitator is someone like a charge nurse, but it certainly doesn't have to be that person. It can often be whoever the unit selects, right? So remember, this should be a unit level decision. But that person is responsible for making sure that the right people come, and that when someone doesn't show up, that's the person who goes and finds that the one who didn't show up and says, hey, you missed the interdisciplinary care conference today. We need to make sure you're there tomorrow. That's also the person who keeps the agenda going, who facilitates the actual conference, keeps things running, and then also the person who makes sure that any action steps or follow-up steps are carried out by whoever the owner is.
Great, thank you. Very helpful. And we'll consider this our final question. If we didn't get to yours, I will be sure and circle back to those of you who didn't get your question answered just yet. How do you think technology is changing the game for communication?
Oh, technology is huge. I mean, we just saw one example with Lehigh Valley's patient roadmap. There are lots of other examples. There's a whole host of technologies. PerfectServe, right, is a great example. It's something that makes it easier and faster to get in touch with the right care team member at the right time, and really get a more immediate response. That, of course, also means fewer unnecessary disruptions, right? So if we're reaching out to the right person, if we're getting an immediate response from that person, we're not pinging people and potentially interrupting their other patient interactions. That can have an impact on efficiency as well as patient experience. So we are seeing just an actual explosion of technology today. And I think I'd also mention that technology is not only having an impact on and improving nurse-physician communication, but also an enormous impact on communication between clinicians and patients. So one example that comes to mind is a practice we saw called the SNF transfer expert. So a dedicated RN who is doing a video handoff from the acute care setting to the skilled nursing facility with the receiving caregivers at the skilled nursing facility, and they're using iPads to do it, or a tablet, and either FaceTime or some other video technology where the patient, before they even get to the skilled nursing facility, gets to meet the care team and even gets to see the space that they're going to be transferred to. Really just a neat practice, and we're seeing lots more practices like it.
Well, thank you. That sounds like an interesting story in itself right there. Catherine, thank you so much for your insight and your experience that you shared with us today. For those of you that joined us today and asked great questions, thank you for that. We do have a question for you, audience. If you would like additional information on PerfectServe and how we can help streamline your clinical communication process, you can let us know. There's a poll on the screen. Let us know if you're interested in learning more, and we can certainly get some information to you. If you enjoyed today's webinar, we do have a calendar of future events coming up. These events are always free, and you can register for them at PerfectServe.com by clicking our Knowledge Center tab. Our next event is actually next Tuesday, May 5th, and Doug Bonnicum is our speaker, and he's actually one of the originators of SBAR that Catherine mentioned. He spoke previously on a webinar for us, and this is installment 2 from him, so it's going to be a great one. We also will be talking about iPass, a handoff program, as well as a focus on patient-centered medical homes in July. So I hope folks can join us. Thank you again, Catherine, for sharing your knowledge with us today, and thank you to the audience for joining us for today's webinar. Please take a moment and tell us how we did before you exit. Have a great afternoon.